We are live.
Okay. So, good evening, postgraduates, and welcome to this 55th episode of All India Postgraduate Teaching Program and initiative from ARC AIS. We claim this our PG program to be different compared to other postgraduate teaching program because we cover the uncovered aspects in other teaching programs like case presentations, journal clubs, OSCEs, and didactics on topics only when they are not comprehensively available at a single go in a textbook. So today is the 55th episode of this series, which was started during about a year back. And this is going to be a didactic lecture on a subject called sympathetic ophthalmitis. This has been a long question in one of the MS finals. Also, it has a lot of importance because this inciting condition, which was responsible for a lot of enucleations in older days following a trauma, is now better controlled because of availability of better immunosuppressives, steroids, and better understanding of the pathophysiology of this disease. And so many a times you do not need any enucleation and can be managed well. And most of the eyes, which are supposed to be the inciting eyes, or the traumatic eyes, can be salvaged, and you should make an effort to repair because of the better availability of the immunosuppressives and the steroids and the other pharmacological agents. So let us see Dr. Malika Goyal, who is one of the senior most retina surgeons from our country, who is a consultant at Retina and Vitreous Services at Apollo Health City, Apollo Hospitals at Hyderabad. She will be speaking to you about sympathetic ophthalmia. You are really privileged to have such a senior person speaking to you. She is supposed to be one of the big names in Vitreoretinal Society. Also, my special thank goes to Dr. Abhishek Anand, who is an associate professor at RIO IGIMS Patna, and my dear friend Dr. S.T. Murlidhar, who is the chairman of Dr. Murlidhar Eye Hospital, Bhubaneswar. Dr. Himanshu Deshmukh, who is a consultant retina and uvea at Deshmukh Eye Hospital, Amravati, could not make it because of some family emergencies, but thank you for agreeing to be part of us. So without much ado, can I request Dr. Malika ma'am to share her screen?
Just a second, I think. Thank you very much, Dr. Prashant Bhavankule, for this opportunity, privilege, and the introduction. It's my proud privilege to present my experience and thoughts on sympathetic ophthalmia. So this is a relatively rare bilateral granulomatous panuveitis following an accidental or surgical penetrating injury to an eye, which is the inciting eye. Am I audible now, Prashant?
Yes, ma'am. Yeah.
Okay. So this can develop as early as 5 days or as late as 66 years following an injury. So these are the reported cases, 5 days or 66 years. So it was first noticed by William Mackenzie in people who were working in the iron works, that when there was a penetrating injury, there was a development of bilateral iritis and atrophic bulbi. And it was Elchnik who first found that there was a role of autoimmunity in this disease. In 1985, Dr. Narsingh Rao highlighted the role of retinal S antigen, which is the central antigen causing this autoimmunity. Now, penetrating injuries provide this autoantigen access to the periocular lymphatics, which are around the conjunctiva, which triggers the cascade of immunogenic events leading to sympathetic ophthalmia in the other eye. Just a second, I'm trying to improve my view. Just a second. Marak et al. Found that the incidence would be about 0.2 to 0.5% following penetrating injury and 0.1% after intraocular surgery. But it is important that repeated inciting events, if there are repeated injuries or repeated surgeries, that greatly increases the risk of developing sympathetic ophthalmia. And in recent years, there has been a relative increase in post-surgical sympathetic ophthalmia compared to post-surgical, post-injury sympathetic ophthalmia. In fact, post-injury incidence has been reducing. The average age of presentation is between 40 and 45 years, and men have much more commonly than women. Now, 50% of the patients will have onset of symptoms within 3 months, and 90% of the patients will have within a year. The factors that contribute to the development include surgical repair of the injury more than 48 hours after the event, or treatment with steroids starting more than a week after the initial injury, or a size of the wound more than 5 millimeters. There seems to be a genetic predisposition to development of this disease, and the important HLA associations are mentioned here, chiefly the two which are highlighted, the HLA-DRB1 and DQB1. The traumas that can cause sympathetic ophthalmia are not just open glove injury, but even just concussion, closed glove injury, even chemical injuries and thermal injuries can cause sympathetic ophthalmia. With regard to surgery, almost any surgery, including paracentesis, can cause sympathetic ophthalmia. So there is just a cyclocryotherapy, a laser cyclophotocoagulation, all of these have been known. Just a radiation of a choroidal melanoma has been reported to cause sympathetic ophthalmia. Of all the surgeries, the maximum risk lies with vitrectomy, surprisingly, and this is because of the retinal manipulation leading to release of the retinal S antigen, and also because there is uveal incarceration at the wound sites, which further releases the uveal antigens into the subconjunctival lymphatics or around the conjunctiva lymphatics. So the risk of sympathetic ophthalmia is actually increased after the use of transconjunctival small gauge vitrectomy because of the increased incidence of wound leak leading to subclinical uveal incarceration and again exposure of ocular antigens. Multiple vitreoretinal surgeries and repeated handling of the uveal tissue greatly increases the risk. Now, this is a patient, as an example to show post-vitrectomy. This was a 55-year-old male who came to me with right eye globe perforation with anesthesia needle during his cataract surgery, which was done elsewhere. He came aphakic. So we did his retinal detachment surgery following the globe perforation. And you can see that after the retina was attached, but after a few months, he developed vitritis with the Dallen-Fuchs nodules. And the other eye also at 6 months developed vitreous haze, disc edema, sunset glow fundus from depigmentation, and Dallen-Fuchs nodules. However, we realized promptly and started him on steroids so that his final vision continued to be 6/6, even though both eyes were severely depigmented at the end of 3 years. But vision continued to be 6/6 in the fellow eye. Other diseases which can cause sympathetic ophthalmia can be just keratitis without any injury, acanthamoeba, fungal, or bacterial keratitis. Earlier, it was believed that infection would reduce the risk of sympathetic ophthalmia. But now it is found that coexisting infection in an injury can actually increase the incidence by allowing increased inflammation and increased exposure of the retinal antigens to the lymphatics. Further, the bacterial products actually act as adjuvants to the retinal and uveal antigens. So the risk of sympathetic ophthalmia increases with endophthalmitis. Now, the pathology, coming to this pathology, it's a diffuse granulomatous inflammation involving the entire uveal tract, and the cell composition is primarily of lymphocytes, plasma cells, multinucleated giant cells, epithelioid histocytes, and eosinophils in the chronic cases in the inner choroid. Choroid is the main seat of activity, while retina is mostly spared. And though choroid is involved, choriocapillaries are again relatively spared, and absence of necrosis is a characteristic pathology feature. This is a histopathology specimen showing an exudative retinal detachment, which is seen in almost 50% of the patients that have severe inflammation, and thickened choroid, particularly at the posterior pole. The choroid is infiltrated by lymphocytes and macrophages, separated by groups of multinucleated cells and epithelioid cells. And as mentioned earlier, the retina and the choriocapillaries are relatively spared, whereas the choroid is diffusely infiltrated with monocytes, lymphocytes, And the large choroidal vessels are congested, but not the choriocapillaries. In 30 to 40% of the patients, there can be yellow-white dots, which are characteristically seen in this disease and known as Dahlen-Fuchs nodules. These usually lie between the RPE and the Brooks membrane and are actually clusters of macrophages and epithelioid cells which contain pigment. So this is the accumulation of macrophages beneath the RPE, seen as a dark brown line because it contains pigment. Though clinically it is not seen as dark brown, but it is seen as yellowish white. Now, it's primarily the pathogenesis is a cell-mediated immune response to the retinal antigens, and it's a delayed type of hypersensitivity. The implicated retinal antigens include retinal S antigen, rhodopsin, and the interphotoreceptor retinoid binding protein. So as mentioned, it is a predominantly T lymphocyte activity, especially the helper cells, the CD4 cells, rather than the CD8 cells. B lymphocytes come much later in long-standing disease. Clinical features can involve anything. There can be anterior inflammation as iritis, mutton fat capes, posterior synechiae. IOP can be low or high as in any other uveitis. Posterior segment findings, the characteristic can be again anything, vitreitis, choroiditis, retinal vasculitis, but the characteristic signs are an exudative retinal detachment and the yellowish white Dahlen-Fuchs nodules. Also, in the chronic cases, sunset glow fundus due to extensive depigmentation of the choroid and RPE and subretinal fibrosis. Secondary glaucoma and cataract, as in any other uveitis, can be seen, as well as choroidal neovascularization. So these are mutton fat capes in the front, and at the back you can have multifocal choroiditis, sunset glow fundus with Dahlen-Fuchs nodules, which initially have substance, meaning they are elevated, giving a dome-shaped appearance under the RPE, but later on they become atrophic and punched out lesions. They can be large and confluent. Mostly these are peripheral, but they can also be seen over the posterior pole near the disc. Vitreitis with multifocal choroiditis. And you see in the right eye, there is a repaired globe. And in the other eye, you see, this is the left eye. In the other eye, you see subretinal pigmented streaks, as well as sunset glow fundus. This is retinal vasculitis with white dots over the macular region in a sympathizing eye. You can have peripapillary atrophy and neovascularization of the disc. So your index of suspicion has to be very high when an eye is behaving very abnormally and the other eye has had surgery or injury. Then your index of suspicion needs to be very high. This is an eye operated in the right eye. This is from, the right eye operated for retinal detachment, and both eyes developed exudative retinal detachment, which resolved with treatment and left behind chorioretinal folds. Multiple choroidal granulomas. Investigations are important to make the diagnosis and monitor response to treatment. Very important is ultrasound. When the media is hazy, it picks up choroidal thickening and exudative detachment. This is an eye, the right eye is the inciting eye. You see the excessive choroidal thickness and the sympathizing eye as well. Fundus fluorescent angiography is very important. There are two types of pictures. The most important is, or the commonest is, the multiple pinpoint hyperfluorescence, as you see in the third image here. And in the later stages, it starts pooling. Again, you see multiple pinpoint leak in the early phase with leakage into the exudative RD in the later phase. The less common type has hypofluorescent spots early in the phase that become hyperfluorescent, and this could be due to the Dahlen-Fuchs nodules which are blocking the fluorescence, such as this patient where you have hypofluorescent lesions becoming showing pooling in the later phase. There can be scars in the periphery which will show window defects or retinal vasculitis, as in this patient. ICG is not very useful in sympathetic ophthalmia. As you see on the right side images, it is showing hyposynescent lesions and the choroidal vascular circulation is not clearly seen. But whereas the FFA shows the disc leakage as well as hyperfluorescent lesions. OCT again can show the neurosensory detachment of the retina as well as the EDI OCT. Okay, we'll come to that later. The OCT can also show the Dallin-Fuchs nodules, as you see on the left, as well as on the right. The larger nodules can come into the inner nuclear layer with ruptures in the Brooks and the RPE. So these are different types of Dallin-Fuchs nodules on OCT. Diffuse choroidal thickening. Choroidal thickening is very important to monitor response to treatment. And choroidal vascularity index is a recently introduced biomarker, which is more stable and less influenced by physiological factors than choroidal thickness. EDI OCT, enhanced depth OCT, allows us to see the choroid better than even B-scan, but the media has to be clear. So as you see, there is loss of choroidal architecture and choroidal thickening in the first scans, but as treatment proceeds, the choroidal architecture returns with loss of the thickness also reduces. OCT angiography, not very useful. It can show flow voids in the choriocapillaries, which resolve with treatment, but it's more important for the detection of CNVM, choroidal neovascular membranes. Differential diagnosis, really speaking, it's a clinical diagnosis and the history is very typical. The other eye has had injury or surgery. But more important is when you suspect it in an injured eye or a operated eye, we have to be sure that we are not actually dealing with a post-traumatic infection rather than sympathetic ophthalmia, because treatment is diametrically opposed. Or we are not dealing with a lens-induced inflammation because there is lens injury. And these can coexist with sympathetic ophthalmia as well. So that differentiation needs to be made before starting treatment. One of the diseases that most closely resembles sympathetic ophthalmia is VKH syndrome, both being granulomatous panuveitis, both having exudative retinal detachments, and the FFA in both being identical, multiple pinpoint hyperfluorescent lesions with late pooling. However, the dermatological signs of VKH syndrome are characteristic and are less commonly, but also seen in sympathetic ophthalmia. Similarly, CSF pleocytosis and meningeal symptoms may also be seen in sympathetic ophthalmia, but less commonly. Sympathetic ophthalmia can mimic any panuveitis and any posterior uveitis. So that we have to see the other features, associated features. But importantly, it can manifest as present as CSCR. I had this young policeman who lost one eye in a lathi charge, and then he came with blurring of vision in the other eye. And there was a serous detachment which looked very much like CSR. We did an angiogram, and this showed typical multiple punctate hyperfluorescence with late pooling. And so we treated him as CSR with good result, as sympathetic ophthalmia. Now, if we had started him on steroids and this was CSR, that would get worse. So it's very important to do an angiogram when you suspect that it may not be CSR. Intraocular lymphoma is another confounding disease which may mimic sympathetic ophthalmia because it can cause multifocal infiltrates, and neuroimaging and a subretinal biopsy from the lesions may be required for the diagnosis. Both can cause exudative retinal detachment as well as uveitis. So coming to management, as I said, first we have to be very sure there is no coexisting infection before we start steroids. And if there is coexisting infection, then start aggressive antimicrobial therapy as well as steroids. So the initial management includes high-dose steroids, which can be pulsed intravenous therapy with 1 gram per day for 3 to 7 days, or just oral prednisolone high dose, 2 milligram per kilogram per day, tapered off over 2 to 3 months. At the same time, immunosuppressive therapy should be started because this is a chronic disease. So immunosuppressive therapy should also be started right in the beginning with the steroids. And we can start with either anti-metabolites, which are azathioprine, methotrexate, or mycophenolate mofetil. For more severe cases, alkylating agents such as cyclophosphamide. And then biologics for even more severe cases like adalimumab or infliximab. Now, these biologics are increasingly becoming the first line of treatment instead of being the last resort, because they target the specific cytokine TNF alpha, which is involved in the pathogenesis of sympathetic ophthalmia. So infliximab or adalimumab are becoming increasingly popular. Of the two agents, the adalimumab is better because it has a higher, longer-term quiescence lower rate of adverse effects. It has the convenience of a subcutaneous injection versus the intravenous required with the infliximab. And it is only once in 2 weeks, whereas infliximab requires everyday injections. So no hospitalization and also it's less expensive. Tocilizumab is a specific biologic used for refractory cases because it's a stronger agent. Intravitreal steroids, which could be IVTA, dexamethasone implant, and the sustained release fluocinolone, which we don't have, can reduce the requirement for systemic anti-inflammatory therapy, as well as are more potent for macular edema, etc. Of course, they have their own side effects, which we need to monitor. Intravitreal anti-VEGF injections for associated CNVM, but long-term immunosuppressive therapy can reduce the risk of developing CNVM. Now, coming to the most important part, prevention, as Dr. Prashant Bhavankule has been emphasizing. How do we prevent sympathetic ophthalmia? By prompt and meticulous primary repair of open globe injuries, prompt control of inflammation, and then as a last thing is removal of the injured eye when surgical repair is impossible or there is zero visual prognosis. So what is the time to enucleation? If it is decided to do it, it should be done promptly because it has been reported as early as 5 days after injury. However, this is controversial. It is important to repair these eyes and not remove them right away because we cannot predict at the presentation what will be the final visual outcome. Many of these may look bad, but ultimately recover very good vision. And also, patient needs time to adjust to the idea of removal of his eye. So give them time before we remove. And then there are now very good treatments for sympathetic ophthalmia. So it's not an incurable or a death warrant for the eyes. So it's not necessary to remove for that reason as well. And if the other eye does develop sympathetic ophthalmia, it may be that this eye, the inciting eye, may be the better eye finally. So for these reasons, it is becoming much less popular to remove the inciting eye. So every attempt should be made to operate early, meticulously, and start anti-inflammatory immediately and keep the eye as far as possible. But repeat surgeries in traumatized eyes can increase the risk by 10 times and hence avoid unnecessary additional surgery in eyes that have minimum visual potential. Thank you.
Very well. Thank you, Dr. Malika. It was quite a lucid presentation and quite
Thank you.
brief and very well said. I had 2 or 3 questions just in on my mobile. The one had asked what is CVI, and one had asked what is EDI.
That is an enhanced depth OCT where it has a greater penetration. So choroid is seen better. You can have.
Show it on our presentation so that they understand.
Okay, I'll have to share it again.
It's from a postgraduate so they just should understand.
This one, I think, yeah. So this is an enhanced depth OCT, which is, showing, I don't know, my cursor is not showing here, but the white arrow shows the choroid. Now, in a normal SD-OCT, which is not EDI, we do not get much of choroidal information. We get retinal and some superficial choroidal information, but this goes much deeper, enhanced depth. So it goes much deeper and shows the choroidal architecture and thickness much better.
So just for to add up to what Madam has suggested, in a time domain, if you have a time domain OCT in your place, well, it will not be possible. In a EDI OCT, there is a sorry, not EDI, in a spectral as well as SS, this facility is available where you have to offset and take it deep. So that helps you in better penetration. You initially get a lateral, which is reversed by the EDI particular thing, and it is basically done to study the choroid. It tells you better visualization of the choroid. And other question was Madam CVI, they had asked one of them.
Sir, can I add one more point, sir?
Yeah, please. Of course. It's open to discussion when we are talking.
So just enhancing on this whole concept of EDI. So when we had time domain and then we have spectral domain OCT, and now as sir has said and ma'am has said that now we have swept source OCT also. So EDI was a term we were used by Zeiss company, Carl Zeiss first of all, and EDI started being for an offset as sir has announced that we wanted to see what is happening in the choroid. Now with the use of swept source OCT, which is now 1040 nanometers, so they have a better penetration, and then you can see the choroid more better. So swept source OCT is being made by Triton, and I think uh, Stopcon and one more company has come up with swept source. They use a swept source beam, that is 1014. That is.
Yeah, great. Thank you, Abhishek.
Prashant, can I make a comment?
Of course, of course.
Okay. First of all, I think Malika, it was a very wonderful presentation covering most of it.
Thank you. Thank you.
I just had a couple of comments that I thought would be beneficial.
Yeah,
The
Murli,
EDI,
Murli,
EDI,
EDI के ऊपर पहले बात करो, फिर CVI. Those are PG questions. Then we'll come to discussion. Yeah, fine.
yeah, the EDI stands for Enhanced Depth Imaging, which is actually a patent from the Spectralis group or the Heidelberg Engineering. And this is typically done by refocusing instead of on the retinal layers to refocus the image on the choroid. So the starting point is the retinal pigment epithelium on the top. And when you go downwards as you go by, then you get to the scleral margin. So the area between the two is the choroid. And the choroid again, which is adjacent and underneath the RP is the choriocapillaries. And then you have the middle layers and the large vessel layers of the halars and settlers. Now, the choroidal vascular index is actually a concept which was done by the three-dimensional activity, providing what is the volumetric analysis of it. So it is a prognostic indicator while you are treating to see how the diffuse choroid thickness is decreasing with your responding to the treatment. That's what the CVI is all about.
It is the ratio.
Thank you.
I mean, it is the ratio of the vascular area
versus
the
the
choroidal area versus the
choroidal area. Yeah.
Prashant, you are muted. You are muted.
Yeah, if we can show it on the slide, I think it will make better sense for the postgraduate.
I think I did not have a slide. I just mentioned it in passing.
No, see, choroidal vascular index is actually, there is a grid. And based on that, they do it. And there's a software on which you actually load the things. Last time that I had a talk with Rupesh Agarwal, the one who actually designed this CVI from Singapore. So he said that he has got a site and a software from where you can actually log in with your choroidal vascular details. And that software really works on it and then brings out the index.
So exactly.
It's not something.
Yeah. So students, it is the ratio of the stromal tissue and the vascular tissue. So it is a ratio of that two in that particular segment, which is to be understood. Yeah. So that is what Dr. Malika madam wanted to say, that is affected by in a sympathetic ophthalmia.
Any disease, any inflammation will increase the vascularity. So as the treatment will proceed, it will reduce. The vascularity component goes down. So that is how any disease, CVI will help in monitoring any disease.
Okay. In fact, VKH and sympathetic ophthalmia have been termed as stromal choroidal disease. It's a stromal choroidal disease. So they actually think about the thickness parameters of the choroid stroma.
One more question before we go on with the discussion. Madam, how do we differentiate between a VKH and a sympathetic ophthalmia in an insignificant trauma?
In an insignificant trauma, case of trauma.
That's what the question says.
Well, if there is trauma, our antennae has to be very high for sympathetic ophthalmia because that would be quite a coincidence to have VKH and trauma. Fortunately, treatment remains the same. So, but the differentiating features would be that of the age of the patient. VKH may be usually older patient, whereas this would be a probably much younger patient if they're with sympathetic. Associated features, if they have any alopecia, vitiligo, or any headaches, severe headaches, hearing loss, dysaceusis, CSF can be tapped for pleocytosis. So those associated systemic features are more of sign of VKH rather than sympathetic ophthalmia. Then VKH could be unilateral. It could start as unilateral, whereas sympathetic ophthalmia would be bilateral to start with. And a very insignificant trauma is very unlikely to cause a sympathetic ophthalmia which could mimic VKH. So keeping everything in mind, I think it should not be very difficult.
One component is in VKH, they do have prodromal symptoms. So they can present initially at a neurologist or anybody. The second thing is that VKH does have the signs other than the eye involvement, like the skin and the integumentary and the other details. Sympathetic ophthalmia per se, by definition, is if there is a penetrating ocular injury. So a small, insignificant blunt trauma is difficult to comment. If you look at the pathogenesis, it actually says that the uveal tissue has to elucidate some of the antigens, which then gets access to the surrounding conjunctival lymphatics. Then only causes the other eye problems. But if the uveal tissue is not involved much, then the incidence of sympathetic ophthalmia, I don't see anything in the literature according to that. Malika.
Yeah, fortunately, treatment for both remains roughly the same. That is a saving grace. So we need to start steroids and immunosuppressives in both. Both are chronic granulomatous diseases.
Last question, which I am seeing right now in my chat boxes. They are asking, Madam, we are told that the uveal tissue should not come in the section while suturing. Then how come in a blunt injury, the sympathetic ophthalmia?
Yeah, that is very difficult to explain, but it is there, even with paracentesis for that matter, or even just radiation for melanoma. So this has been described with all kinds of things where we cannot explain the pathogenesis as we know. So this shows that our understanding of pathogenesis may not be complete. We are assuming that this is the only way, but there may be other ways of causing sympathetic ophthalmia.
One other component is the genetic predisposition. Some people are more predisposed to the sympathetic ophthalmia than the others.
Yes.
So I think I have exhausted the questions right now on my mobile. We can now continue with the discussion. Now, I think Abhishek and Dr. Murli, we can complement and add to the discussion whatever you think has been missed out from the postgraduate sense in the topic.
Sir, one thing is that one very important aspect is that how to can we summarize that if generally PGs are involved in suturing and repair of all the blunt trauma that come to our most of the setups. So how to decrease the incidence and what are the practical tips that they can get so they can minimize. So let's take a hypothetical case of a trauma open globe injury and there is incarceration of the iris at the and it's a tissue and the uh, the 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 open I mean the lacerated would be passing through the limbus and also involving the pars plana till forehead and the iris is incarcerated at the corneal rupture. So how to decrease, ma'am? Can you throw lights on the to the student that how should they approach this case to decrease the incidence of sympathetic ophthalmitis in this case? Ma'am, if
well, they have meticulous, I think, repair. You try to see that no tissues are left in the wounds. So either excise the uveal tissue which is coming out, or if it is a fresh injury and clean injury, reposit it. But whatever is done, see that you don't leave behind tissue incarcerated in the wounds, or the sutures are not so wide apart that tissue is coming out for a long time. There is wound leak for a long time post surgery, post repair. So very good suturing, secure wounds, and clean wounds, leaving behind clean wounds, maybe requiring some vitrectomy to clean the wound. if there is vitreous prolapsing through it. So cleaning out everything, the wound should just have the either the sclera or the cornea in the bites, and not other tissue in between, to the extent possible. Everything is not practical, but to the extent possible. Even going backwards, if it is a very posterior rupture, going as back as possible, because again, in the posterior rupture, again, the uveal tissue will be incarcerated. Though we say that we should go only to a certain extent, but at least as much as possible. And then I think one important thing is, since we are talking of starting anti-inflammatory therapy early, there is a high risk of infection then because of the injury. So possibly if also starting a broad spectrum antibiotic systemically, or an intravitreal antibiotic at the time of repair, to prevent endophthalmitis from this systemic immunosuppression.
What are the we can any input from you, Muralidhar sir, and what are the earliest symptoms in the other eye? We as a person who has repaired should be quick looking for, and or earliest signs that they should be keep looking for, sir.
See, management of a penetrating ocular trauma, one thing you have to understand that there's no way that we can actually avoid a sympathetic ophthalmitis if it has to happen. That's the first thing. So all that we do is, when we are repairing, it has to be very meticulous surgical technique. And the goal has to be that we have to avoid any uveal tissue exposure. That is the goal. Having said that, once we have repaired, you have to be very, very careful and prudent in monitoring the post-op inflammation, and it has to be very aggressively managed. This is the component that you have to understand surgically. And the one thing that I would always suggest is that the moment a penetrating injury comes, you don't postpone it. The earlier you intervene, the better is the outcome and the lesser is the chance of a sympathetic ophthalmia. So like if it comes in the night and you have a resident or somebody who says, okay, kal savere aa jao aap, hum kar denge. No, you have to do it immediately. That's the dictum.
So the
Now coming to, tell me.
Yes, yes, sir. So to summarize it, sir, early surgery, as soon as possible surgery, meticulous surgery, cleaning and removing of all the iris incarcerated tissue or any uveal tissue, and
Exposure.
exposure and meticulous closure of the wound is very of the paramount importance.
Yes.
Sir, any input, any
question
input on the
was-
earliest sign and symptoms as a
Yeah.
treating physician you should be looking for, sir, when you are doing
I think, Malika, would you like to take that or you want me to answer?
Yeah. I think the classical first sign is reduced accommodation. So if you have a person who suddenly says nowadays, I can't read, that can be the first sign. Actually, that is classically described as the first sign. And then, of course, just some blurring. If a person who was otherwise having a good eye and now comes and says that my good left eye is, I'm having some blurring of vision, that's very, very dangerous. Then look carefully. This was a symptom, the reading difficulty. The sign can be retrolental cells, just a few retrolental cells on slit lamp. But no, the conjunctiva is white, everything looks normal. But that can be the first sign. So that is where you immediately can start immunosuppression. I mean, steroids at least.
floaters.
In cases
We should
of
sensitize the patient. Sorry, sir. Sir, continue. Sir.
I was saying that in cases of vitrectomies, if you have done multiple vitrectomies and suddenly you find the other eye has inflammatory responses, you must suspect sympathetic ophthalmia and immediately put them for a ultrasound to check for a diffuse choroidal thickening if the media is not clear, and start with aggressive management. And in terms of symptoms, they come with, they can come with a decreased vision, a blurring in vision, redness. They can complain of pain. They can also have, irritation in bright light.
Photophobia.
And photophobia. And typically, if they look at these signs, you will find inflammatory signs both in the anterior segment as well as in the posterior segment, or it could be one of them. In Indian scenarios, it has been seen that the posterior segment inflammation is more commonly seen in sympathetic ophthalmia than in anterior involvement. The other component is the loss of accommodation because of the diffuse ciliary body thickening also, which reduces the accommodation. So I think fundamentally you have to always examine the posterior segment for any choroidal lesions, or sometimes you might even find, the early signs of Dallin-Fuchs kind of a thing, like you could have just hyperplasia of pigments at certain places, or there could be slightly elevated lesions of these yellowish or yellowish white lesions, which are dispersed. And I think all these cases are very early signs that you look at.
So to summarize, I think whenever whenever we have repaired any case of, or whenever we are suspecting a case of sympathetic ophthalmitis, do look out for if you have a loss of accommodation, or if the patient is asking of a change in the change in the visual acuity, or floaters, or there is a redness in the eyes, or such symptoms, subtle symptoms. Do dilate the eye and look for retrolental flare, and look for vitritis. Do a complete posterior segment examination. Look out for classical signs like Dellen-Fox nodules or even vitritis, and start suspecting in that way that this patient can develop a sympathetic ophthalmitis, especially even after subtle injury. Also, they can develop sympathetic ophthalmitis.
I
Great.
wanted to add one thing here. See, classically, we say that sympathizing eye will start showing symptoms as early as 5 days, and 90% of them actually show within the first year. But I must put a rider here that sympathetic ophthalmitis can happen anytime in the life. So most
Yes.
important is you have to be constantly aware in a penetrating trauma eye, and keep on looking for this on the other eye every time.
Yeah, I think Dr. Malika has already shared 65 years later, na? What was that?
Yeah.
66, yeah, 66
I
years.
think you have that. Yeah.
That's very, very, very well said.
Mhm.
Yeah, Murli, anything more you would like to add, Abhishek?
I
So
actually
there is one.
wanted to say,
Hmm.
I wanted to say something very interesting. Malika just only talked about fluorescein angio and made a comment that ICG is not that useful a thing. But if you look at the early cases, you might not pick up the pinpoint lesions on the fluorescein angio, but you can immediately pick them up on the choroidal ICG. The number of flow void areas in an ICG will be much more than what you will see in the fluorescein angio. This is the first thing. Second thing is the prognosis and the response to treatment, and when to taper and when to stop the medication. My experience of late has been I do the ICG, combined FA ICG regularly. Whenever I need to stop or something, then I typically look for these dark areas on the ICG angio. If they have these hypocyanescent areas, I think it is still for you to continue the treatment. So if the areas are showing, some of them will show completely, like dark areas. So that means the disease is still active. And those which are partial, you can actually compare it with your fluorescein angio picture and then say that, okay, these are responding, this is not responding. So you need to go on for a longer time.
Sir, can I extrapolate your thought process, sir? Like many places don't have access to ICG, but Octa is now available at multiple places, sir. So flow void areas in choroid, have you tried to correlate, sir, whether they
See,
you in Octa flow void
yeah,
areas in the choroid? Try to
typically Octa is not used for
Choroid.
looking at the flow voids in the choroid.
yeah, but
It's actually looked because important thing in one of the clinical features of sympathetic ophthalmia is a hyperemia, or you can see an angry, active disc on fluorescein angiography. So in those cases, you have to constantly look for the area around it if you are having pinpoint leaks, or
Yes.
you can have few cystic spaces, or if you find some amount of window defects in those areas which are actually due to pigment masking the underlying choroid,
Yes.
then those cases you must immediately think about CNVM and start treatment, because they don't present classically as a classic CNVM. So this is the advantage of the Octa in these cases, where you can actually pick up the abnormal hyperplasias on the pigment epithelial layers, which will suddenly throw out as a CNVM. So Octa's role is mostly for detecting early CNVMs, and in few cases, because Octa is not sensitive towards the flow void areas of that pinpoint nature.
Yeah, I think the points you made about ICG are very good. Uh, but I think to monitor treatment, you could use something non-invasive as well to decide about activity, like choroidal thickness on the B scan or on the OCT. Particularly B scan, I think, is very elegant in showing it. So at least I have mostly used non-invasive methods to decide when we can stop treatment or if my treatment is working or not. So immediately the choroidal thickness, and if the choroidal thickness has been normal for a very long time, and then we can start thinking of discontinuing treatment. Um,
Yeah. The
Well,
only thing I do is I do a repeat of a FA and ICG combined at that time. And then if I see the image which doesn't show any dark spots on the ICG, then I'm very certain that, like I can now think about relaxing in terms of treatment. But this particular thing is more more significant if you're dealing with a VKH than in a sympathetic ophthalmia, where the ICG actually is a guide for when to stop the treatment in VKH.
if sympathetic ophthalmology is mainly a clinical diagnosis, so what are the investigations that we must do post we have made up that this is the clinical diagnosis? Then what are the investigation a person must do to monitor the treatment or to prognosticate the disease?
um, I think the most important to again would be a B scan,
B
OCT.
scan.
B scan
B
is for
scan.
diffuse choroidal thickness.
Yes, ma'am.
Or exudative retinal detachment to have the height of the detachment as well.
Okay, ma'am.
OCT to monitor the height of the serous retinal detachment, so that monitoring the treatment. And if the OCT can also show choroidal thickness, then that. So I think as non-invasive tests, these are good enough. I would probably not do an FFA or an ICG to even make a diagnosis. If I know it's an injured eye or an operated eye, other eye is reacting,
Yeah.
I'm having choroidal thickness, I'm having serous detachment, I'd probably not do anything more and just start treatment and then monitor on these non-invasive tests. But yes, if we want to be very meticulous and document everything, then we should do an FFA ICG so that later on we can show reversal of these changes, as Dr. Murli was saying. We can show the reversal on treatment. But practically speaking, I think B scan and OCT are good enough.
Yeah, can
So,
I add to it? I
yeah.
think what we do is basically we monitor with the help of a OCT and an Octa as well. Sequential angiography, which is an invasive thing, I would also be a bit skeptical about it, because OCT has certain features which all the postgraduates should remember. Whenever there is an inflammation, call it a VKH or a sympathetic, the serous fluid will have lot of proteinaceous type of it. It will be having undulating type of a serous retinal detachment, multiple pockets of it. Second thing is the choroid becomes thickened as well as it becomes featureless. That is what you should remember whenever you have such a significant inflammation. And this will help you out in understanding that the seat of activity is into the choroid. So once it becomes featureless on an OCT, it is either sympathetic or, this type of a thing. And it can help you sometimes if you are confused, Kitty, is it a multifocal CSR? Well, featureless CSR, thickened choroid, will go against CSR. This is how we look at it. Octa, I would agree with Abhishek that sometimes you do see in inflammations voids on in a choriocapillary layers. which are again a sign of activity, which can help you in sequential octas, can show that the voids are slowly disappearing, and this is again a sign of healing which we can pick up on an octa. I do agree with Abhishek that we can do a non-invasive test which can not replace but supplement the need of multiple FFA ICGs.
I think, can I make an addition to what
Sure,
you
sure,
just
sure.
said?
Please.
In the acute phase of an OCT picture that you see, you also see choroidal folds,
Yes.
and you can also see some amount of fluid with certain, pillars, which are actually the split in the bacillary layer. So you have some part of it going towards the RP and some coming up towards the inner retinal layers. And because of that, you can actually have elongation of the outer nuclear layer. So it shows, a swelling that you see on the OCT. So I think
So
some of the features are very important, and the biggest thing is you get a lot of these hyper-reflective dots,
yes.
and these are again inflammatory signs that there is inflammation that we are seeing.
I think we
Then,
missed something about the Dallin-Fuchs nodules.
yes,
They are very classical, but they are also seen in VKH, if I'm not wrong.
yes,
They can
Yes.
yes,
also be seen in VKH.
They can see in both, ma'am.
Yes.
Both.
yeah. The interesting component here is that most of the Dallin-Fuchs nodules are mostly seen in the inferior retina more than the superior.
That is also very
I mean,
important.
that's
Yes.
again
And
something
the
that you have to
sunset
look
glow,
at.
again, the sunset glow also can be seen in both VKH
Both.
and
But sunset glow is more of a chronic sign after
yeah,
it has
chronicity.
healed.
Yes, yes.
More of chronic. So to summarize everything, I mean, the most important is to do. We can go for a non-invasive sympathetic ophthalmitis is more of a clinical diagnosis, and in order to supplement your diagnosis, you can go for more of a non-invasive diagnostic modalities like ultrasound, which is very important. It is available at most of the medical colleges and at all the DNB colleges also. And also you can go for an OCT. Look out for the choroid, look out for a featureless choroid, look out for bumps in the choroid, and also for the bacillary layer detachment and pillar signs in this. In order to further supplement, if you're not in a diagnostic dilemma, you can go for a FFA and ICG to supplement your diagnostic thing.
I'll
So
just
that
make
is
one addition. I'll just make
yes,
one addition, Abhishek. I think we missed completely on autofluorescence as a
yes,
non-invasive
sir. Yes, sir. Yes,
modality.
yes, sir.
And I think one has to be very uh, understanding about what is the acute phase sympathetic ophthalmia autofluorescence patterns and what is the chronic phase autofluorescence patterns.
Right, sir.
I think these are extremely important, because if you see that, you might have, like a lot of these cysts that can be seen, and in the autofluorescence you might find a halo which actually indicates the same septate kind of a thing because of the split in the bacillary layer. Those are the things which are very interesting, and you must understand that the autofluorescence actually detects the amount of lipofuscin in the RPE, which actually enables the visualization of, like the amount of dysfunction or the cell death. So it helps you both in the acute phase, and it also helps you to monitor your treatment as you go by. The resolution gives you a different picture on the
So
autofluorescence. I think autofluorescence is very important.
yes, sir. That is true. Autofluorescence, we all, even at PGs, you should must know, because if your question can come on autofluorescence, as well as if you are giving
Yeah.
a very good viva, then it can go to this, that if the examiner gets interested that you know a lot about the subject, certainly OCT more on fundus autofluorescence. Also, we have uh, used the term bacillary layer detachment multiple times. So generally, this question will not be asked to you all, but if basically it's a splitting in the myoid zone. So if you can see it on the OCT that there is a splitting at the myoid zone, I mean the ISOS, just around the ISOS junction, and you can see some fluid layers. So that is called bacillary layer detachment, and that is classical of few diseases like sympathetic ophthalmitis or VKH also. So, sir, Prashant sir, any more input?
Yeah,
But there is one question.
what is the
Malika, I had a
leopard spot sign
yeah,
in autofluorescence?
yeah.
Can you
Yes.
describe that? I'm not too good with that. So
See, this is actually, like once the lesion starts resolving, okay, then these are actually the areas of hyper and hypoautofluorescence. And they typically present, in a numular fashion. And so you have that which resembles the leopard spots. We sometimes see the leopard spots in the periphery in cases of, like primary intraocular lymphomas in the healing phase. So it's typically in that kind of a chorioretinal, atrophic lesions which happen in the Dellen tubes. That's how it is. And I had a question for you, Malika. This is a case which had a sympathetic ophthalmia. You treated with steroids, and the guy came back with CSCR in the other eye.
are you talking about the case which I showed?
No, no. This
Okay.
was another case
Okay.
where this
Okay.
was more, I think, since we are coming to the end of this. So the question was, there is a sympathetic ophthalmia, you have treated with steroids, and about a week or 10 days later, he comes with a CSR in the other eye.
See, other
Can
eye would already be inflamed because you're saying it's sympathetic ophthalmia.
Yeah.
Now, CSR is a very small problem. I mean, you can ignore it in the face of the bigger problem. CSR might settle down even while steroids are going on. Or if it doesn't settle down, it can be treated in most of the times, unless there is a subfoveal leak. Now we don't have PDT, so that we are handicapped. But most of the CSR we can treat. So I would not give too much importance to CSR if we have a more serious thing to worry about right now. Then when we stop steroids, let's say 3 months later or 6 months later, then CSR would hopefully reverse anyway.
Yeah.
Thank you.
Awesome. Yeah.
and also we can think of early moving to steroid sparing agents if it's a
And,
more common.
and moreover, what we can do is we can do an early laser. We can do an angiogram, find the leak, and close the leak while steroids are going on so that
Yes.
we don't have a bullous CSR. So I have done that for many patients of uveitis. When they have coexisting CSR, find the leak, close the leak, and continue steroids.
So, so to the PG, basically the question was that there is a patient of sympathetic ophthalmitis, and then we have started a steroid, and as we know that steroid can cause CSR. So it's a dilemma that how to continue the steroids for the other eye as well as not to cause more worsening of the CSR due to steroid. So this question was being answered in the previous discussion.
So we had a great discussion. Any more inputs from either of the three of you?
I only wanted to say that subretinal fibrosis that is reported in sympathetic ophthalmitis is pretty rare in our country. I do not know the reason. I have yet to see a subretinal fibrosis in a sympathetic ophthalmitis with exudative retinal detachment. Any comments on that, Malika?
Well, even where it is reported, they admit that it is rare. It is not, it is mentioned as rarely. And then sympathetic ophthalmia, it's rare, itself is rare. So obviously we don't see much.
True, true.
I think it's
Yeah.
almost 9 o'clock. So we had a wonderful, fruitful discussion, and we have one more comment. See, we are having viewership from Uzbekistan. So
Oh,
Murad Said Bekov, he has hello from Uzbekistan. Thank you for the webinar. So
thanks for
Dr. Malika,
Congratulations to you and ma'am, sir.
yeah.
it basically goes to Dr. Malika and both
Yes,
of
ma'am.
Dr. Abhishek and Dr. Murli for making it so interesting that we get a comment from in our chat box from that end. So thank you once more, everyone. I think I need to thank Dr. Malika for, in fact,
So
when I approached her.
there are, sir, do you have some time? I think there are two questions from Dr. Rajiv. And
Why not? Why not? We will come. Yeah.
so
Yeah.
one question is regarding, is change in choroidal vascularity index is predictive marker for sympathetic ophthalmia? So that is a very interesting question. I don't have experience in that, so I would ask ma'am or sir to answer this. And one other question is from Dr. Why HLA association with sympathetic ophthalmia? So
Okay. See, to my knowledge, I don't do much of this CVI, choroidal vascular, but to my knowledge, any inflammatory event would increase the CVI, and as the disease resolves, it would revert to normal. But Dr. Murli can correct or add to that. The second is that it is HLA is what is a genetic input we all have. We all have some these things. So if we have those particular HLA types, then we are more predisposed to certain diseases. Like HLA-B27 does not necessarily mean I will have iritis, but it predisposes me to have iritis. HLA-B51 predisposes me to have Behçet's. So similarly, those HLAs, if you have, you are more predisposed to have sympathetic ophthalmia. So that is your genetic predisposition, constitution.
I think this vascularity index, and I also don't have much of it. I tried at it a couple of times, but then I started bothering Rupesh more than what I could understand. So I gave up. But there are two indexes that they talk about. One is the vascularity index, and the other is that as the treatment is responding, then the severity index is actually also assessed along with that. And these two indices are a prognostic indicator for the response to the treatment. But honestly, I'm not able to understand that concept. I know he was telling me about some grids are there and you match it and you can get to that.
So,
And,
so I have
based on the ratio.
so I have done a
So I'm
few.
not.
I have been investing some of my time on CVISF for
Mm.
last few months. So basically, what Dr. Rupesh and Dr. Jay have been able to do is that they have developed their own licensed software, and we can also do the same by using an image software in which you. And so the basically the hyper reflective, hyper reflection. So so we have a dark areas and we have hyperreflective areas in the choroid. So the dark areas are representative of the vascular flow, and the hyperreflective areas are supposed to be the stromal areas and all this. So what we do is we binarize this image, and just under the fovea we take 1,000 micron cut, and then under that area we try to understand that how much of this choroid area, what how much are hyperreflective dots and what percentage is occupied by the hyperreflective dots and what percentage is occupied by the dark dots, and thus we take out the ratio, and that is what we call as a CVI or choroidal vascularity index. We try to do it by image software, but then they have developed more advanced version of this analysis. So what we are trying to do is more in a crude way. And regarding question from Dr. Raji, I think uh, per se, I don't think that sympathetic ophthalmia is a disease of the choroidal vessels. It's more of a stromal disease. So might be CVI might be not that good predictor for for sympathetic ophthalmia. That is what I feel.
Anything more? I think. So I think we had a wonderful, fruitful discussion. I hope postgraduates you had a good learning. As I had promised, we had Dr. Malika Goyal, who is one of the most eloquent and very versatile vitreoretinal, senior most vitreoretinal surgeon of our country, and you could understand how lucidly she has presented her presentation. It's a slightly difficult topic for you, but I'm sure she has made it quite easy for you now. And of course, my special thanks also goes to Dr. Murlidhar and to the professor who was awakened. His teacher in him has had suddenly awakened during the discussion, and I liked that about it. The way he was taking forward the discussion, and that's what we want from every one of you. Thank you, Abhishek, for getting your teacher awakened in you and helping us in putting across the
Thank,
subject to the students at large, because they are the ultimate beneficiary. And you being in a teaching institute, naturally you can feel the pulse of a student better than most of us. Thank you for being so very well directing the discussion at the end as well. So
thank you,
thank
sir.
you.
Thank you. And thank you to ma'am and sir for taking out the discussion. Thank you, Murli sir, and thank you, Malika ma'am,
Anand and
and thank you,
Murli.
Prasad sir.
Thank you.
Prashant, really obliged for this great
Right,
discussion
ma'am.
session.
It's a privilege
Thank
to
you,
have
Prashant.
people like you for our postgraduate. I am indeed indebted to all three of you for sparing your time for the postgraduates of our country who are going to be the future of Indian ophthalmology. So every one of us who is investing time, we are doing a service towards our nation, and I'm thankful on behalf of students to all three of you. And so postgraduates, we will be meeting again on coming Thursday at 8 p.m. with something different. Till
Sir,
then, time for us to say bye.
one last,
Please,
sir.
please,
Sir,
Abhishek.
AIOC, ARC, PG teaching program is happening from 6 to 8 September. Can you please
Yeah.
invite the East Zone students for on that?
Yeah, so the postgraduates from the East Zone, we are having a physical postgraduate teaching program on 3 days, 6 to 8 September at RIO Patna. Dr. Bibhuti and Dr. Abhishek are the host over there, and they're working very hard to make it very interactive. This is basically designed for postgraduates who are the final year residents. It's like a final summary of it, and it is going to be a revision classes, and the capsule will be conducted by very senior people who are good teachers, and they will be helping you out in understanding various topics. So do register, do take help of the Sun Pharma people. They will be helping you out in registering for it. It's a 3 days residential program. And once you register, it's totally free. Your travel as well as stay will be taken care by the Sun Pharma, and the teaching program will be, of course, drafted by AIOS in conjunction with the RIO Patna. So
Thank you, sir.
we are looking forward to meeting you there as well. So then bye bye from all of us. Thank you once
Bye
more.
bye.
The three
Bye
people.
bye, sir. Bye. Thank you,
Thank you
sir.
very much.
Thank you,
you.
sir.